Welcome to our critical care series, where we tackle the most pressing and time-sensitive conditions in medicine. Today, we venture into the cranium, a rigid, unyielding vault that protects our most vital organ. We will be exploring the pathophysiology, diagnosis, and management of raised intracranial pressure, also known as ICP, or intracranial hypertension. This is a true neurological emergency, a condition where the pressure inside the skull rises to life-threatening levels. Understanding the principles that govern this pressure cooker environment is fundamental for any clinician, as swift and logical intervention can be the difference between a good neurological outcome and devastating, irreversible brain injury or death. In this episode, we will dissect the core principles of intracranial dynamics, including the famous Monro-Kelly doctrine. We will explore the different types of cerebral edema that drive this pressure increase. We will then meticulously detail the clinical signs that herald rising ICP, from the subtle clues in an infant to the ominous Cushing's triad that signals impending brain herniation. We will systematically walk through the diagnostic process and, most importantly, provide a highly detailed, evidence-based, tiered approach to management, outlining the rationale behind each step, from simple head positioning to advanced therapies like hyperosmolar agents and decompressive craniectomy. We will also dedicate a special focus to a unique and often enigmatic condition called pseudotumor cerebri, or idiopathic intracranial hypertension. To begin, we must first define what we are talking about. Intracranial pressure is the pressure exerted by the contents of the cranium, the brain parenchyma, the cerebrospinal fluid, and the blood on the skull. In a resting, supine child, a normal ICP is typically less than 15 mm of mercury. Intracranial hypertension is formally defined as a sustained elevation of ICP to a level of 20 mm of mercury or higher. The entire pathophysiology of raised ICP is elegantly explained by a principle formulated over 200 years ago, the Monro-Kelly doctrine. This doctrine states that the skull is a rigid, closed box with a fixed total volume. This volume is occupied by three essential components: the brain tissue itself, which makes up about 80% of the volume, the cerebrospinal fluid, or CSF, which accounts for about 10%, and the intracranial blood volume, which makes up the final 10%. Because the total volume is fixed, an increase in the volume of any one of these components must be compensated by a decrease in the volume of one or both of the other components. If this compensation fails, the intracranial pressure will inevitably rise. Imagine a sealed container filled to the brim with a large sponge, the brain, some water, the CSF, and a network of small balloons filled with liquid, the blood vessels. If you try to add more water or inflate the balloons further, the container will pressurize. The brain's initial response to a growing mass, like a tumor or a hematoma, is to use its compensatory mechanisms. First, CSF is shunted out of the cranium and down into the more compliant spinal subarachnoid space. Second, the low-pressure venous blood system is compressed, and venous blood is squeezed out of the skull. This relationship is described by the intracranial pressure volume curve. Initially, as the volume of a lesion increases, these compensatory mechanisms work well, and the ICP remains relatively stable. This is the flat, compliant portion of the curve. However, once these mechanisms are exhausted, even a tiny additional increase in volume causes a dramatic, exponential rise in ICP. This is the steep, non-compliant portion of the curve, where the patient can deteriorate rapidly. This rise in ICP has a direct and dangerous effect on brain perfusion. The concept of cerebral perfusion pressure, or CPP, is critical here. CPP is the pressure gradient that drives blood flow to the brain, and it is calculated by subtracting the intracranial pressure from the mean arterial pressure, or MAP. So, CPP equals MAP minus ICP. The brain has autoregulatory mechanisms to maintain constant cerebral blood flow across a range of CPP values. However, as ICP rises, CPP falls. If the CPP drops below a critical threshold, which is around 50 to 60 mm of mercury in an older child, cerebral blood flow becomes insufficient to meet the brain's high metabolic demands. This leads to cerebral ischemia. Ischemia, in turn, triggers a cascade of events, including cytotoxic edema, which causes brain cells to swell. This swelling further increases the volume within the skull, which raises the ICP even more, further reducing CPP, and creating a vicious, self-perpetuating cycle of ischemia and rising pressure that ultimately leads to neuronal death. A central element in the pathophysiology of raised ICP is cerebral edema, which is simply an increase in the brain's water content. There are 4 main types of cerebral edema, and understanding them is key because their underlying mechanisms and responses to treatment can differ. First is vasogenic edema, which is the most common type. This results from a breakdown of the tight junctions of the blood-brain barrier, or BBB. When the BBB becomes leaky, plasma proteins and fluid are free to extravasate from the capillaries into the brain's extracellular space. This type of edema is protein-rich and predominantly affects the white matter. It is the classic edema seen surrounding brain tumors, abscesses, and in areas of inflammation or trauma. The second type is cytotoxic edema. Unlike vasogenic edema, this is an intracellular phenomenon. It represents the swelling of the brain cells themselves, the neurons, glia, and endothelial cells. This occurs due to a failure of cellular energy metabolism, specifically the ATP-dependent sodium-potassium pumps. When these pumps fail, sodium accumulates inside the cells, and water follows osmotically, causing the cells to swell and eventually lyse. Cytotoxic edema is the hallmark of hypoxic ischemic injury, such as after a cardiac arrest or stroke, and it affects both the gray and white matter. Third, we have interstitial edema, which is also known as hydrocephalic edema. This is seen in cases of acute obstructive hydrocephalus. The high pressure within the ventricular system forces CSF across the ependymal lining of the ventricles and into the periventricular white matter. This can be clearly visualized on MRI as a bright signal around the ventricles on T2 weighted images. Finally, there is osmotic edema. This occurs when the plasma becomes significantly hypoosmolar relative to the brain tissue. This creates an osmotic gradient that drives water into the brain across an intact blood-brain barrier. This is most classically seen during the overly rapid correction of hypernatremia or during the treatment of diabetic ketoacidosis, where a rapid drop in blood glucose creates a state of relative hypoosmolality. The causes of raised intracranial pressure are numerous and can be categorized based on which component of the Monro-Kelly doctrine is primarily affected. An increase in brain parenchyma volume is typically due to a focal space-occupying lesion. This includes brain tumors, brain abscesses, and intracranial hematomas, whether they are epidural, subdural, or intraparenchymal. Diffuse brain swelling from generalized cerebral edema, as seen in severe traumatic brain injury, acute encephalitic syndrome, or hypoxic ischemic encephalopathy, also falls into this category. An increase in CSF volume is the definition of hydrocephalus, which we discussed in a previous episode. This can be obstructive, where there's a blockage within the ventricular system, or communicating, where absorption is impaired. An increase in intracranial blood volume can occur with cerebral venous sinus thrombosis, which blocks venous outflow from the brain. It can also be caused by conditions that lead to cerebral vasodilation, such as hypercarbia, or a state of hyperemia that can follow a traumatic brain injury. Lastly, there is a category where the cause is not immediately apparent on standard imaging, leading to a diagnosis of idiopathic intracranial hypertension, formerly known as pseudotumor cerebri. The clinical presentation of raised ICP is highly dependent on the child's age, the acuity of the pressure rise, and the underlying pathology. In infants, whose cranial sutures are not yet fused and whose fontanelles are open, the skull can expand to accommodate some of the increased volume. This leads to a unique set of signs. The most prominent is often a tense, firm, or bulging anterior fontanelle. There will be an accelerated rate of head circumference growth, with the measurements crossing percentile lines on a growth chart. The cranial sutures may feel palpably separated. Other signs include irritability, a high-pitched cry, poor feeding, vomiting, and increasing lethargy. The setting sun sign, a persistent downward gaze, can also be seen. In older children with fused skulls, the presentation is a more direct reflection of the high pressure within a rigid box. The classic triad of symptoms is headache, vomiting, and papilledema. The headache is typically worse in the morning, as ICP naturally rises slightly during sleep in the supine position, and it can be exacerbated by coughing, sneezing, or straining. The vomiting is often described as projectile and may occur without preceding nausea, especially in the morning. Papilledema, or swelling of the optic disc, is a cardinal sign of chronic or subacute raised ICP. It is caused by the transmission of high pressure along the optic nerve sheath, which obstructs axoplasmic flow. Early papilledema may be asymptomatic, but if left untreated, it leads to optic atrophy and permanent vision loss. Diplopia, or double vision, from a unilateral or bilateral sixth cranial nerve palsy is also common, as this nerve has a long, vulnerable intracranial course. As the intracranial pressure continues to rise and the brain begins to herniate, a series of late and ominous signs appear. The level of consciousness will deteriorate, which is best tracked using the Glasgow Coma Scale, or GCS. A drop of 2 or more points in the GCS score is a critical warning sign. Pupillary changes occur as the third cranial nerve is compressed, typically during uncal herniation. This starts with a sluggishly reactive pupil, progresses to a fixed and dilated blown pupil on the same side as the lesion, and eventually leads to bilateral pupillary dilation. Abnormal posturing may be seen, starting with decorticate posturing, which is flexion of the arms and extension of the legs, progressing to decerebrate posturing, which is extension of both arms and legs. Finally, the clinician may observe Cushing's triad, a physiological response to severe intracranial hypertension and brainstem compression. This triad consists of systemic hypertension, bradycardia, and irregular respirations. The hypertension is a reflexive attempt to maintain cerebral perfusion pressure in the face of high ICP. The bradycardia is a reflex response to the systemic hypertension, mediated by the baroreceptors. The irregular breathing patterns result from direct pressure on the brainstem respiratory centers. It is crucial to remember that Cushing's triad is a very late and pre-terminal sign. The diagnostic workup for a child with suspected raised ICP begins with a rapid clinical assessment. This includes evaluating the ABC's airway, breathing, and circulation and performing a focused neurological examination, including calculating the GCS score, checking pupillary size and reactivity, and performing funduscopy to look for papilledema. Neuroimaging is the next essential step and should be performed urgently. A non-contrast head CT scan is the imaging modality of choice in the acute setting. It is fast, widely available, and excellent for identifying life-threatening conditions like hemorrhage, large tumors, midline shift, and hydrocephalus. Key CT findings suggestive of high ICP include effacement, or squeezing shut, of the sulci and the basal cisterns, which are the CSF spaces at the base of the brain. MRI provides superior anatomical detail and is better for visualizing posterior fossa structures, detecting subtle edema, and diagnosing conditions like venous sinus thrombosis when combined with an MR venogram. However, it is more time-consuming and often requires sedation in children, making it less ideal for an unstable patient. The gold standard for diagnosis and monitoring is direct measurement of intracranial pressure. ICP monitoring is an invasive procedure indicated in patients with severe traumatic brain injury, defined as a GCS score of 8 or less, or in any patient with a deteriorating neurological exam where raised ICP is suspected. The most common and preferred method is an intraventricular catheter, also known as an external ventricular drain or EVD. A catheter is placed into one of the lateral ventricles and connected to an external transducer. The EVD is the gold standard because it not only provides a continuous, accurate ICP reading but also allows for the therapeutic drainage of CSF, making it both a diagnostic and a therapeutic tool. Other monitoring devices exist, such as intraparenchymal fiber optic probes, but they do not offer the ability to drain CSF. The management of a child with raised intracranial pressure is a medical emergency that requires a structured, stepwise, and aggressive approach. The goals are twofold: to maintain the ICP below 20 mm of mercury, and to ensure an adequate, age-appropriate cerebral perfusion pressure to prevent secondary ischemic injury. The management can be thought of as a tiered system, escalating interventions based on the patient's response. Tier 0 forms the foundation of all ICP management. These are general supportive care measures that should be instituted immediately for any child at risk. First, ensure a patent airway and adequate oxygenation and ventilation. Both hypoxia and hypercarbia are potent cerebral vasodilators and will acutely raise ICP. The head of the bed should be elevated to 30 degrees to promote venous drainage from the head. The head must also be kept in a strict midline position, as neck flexion or rotation can compress the jugular veins and impede venous outflow. It is essential to maintain normothermia, as fever increases cerebral metabolic demand and ICP blood glucose should be monitored and maintained in the normal range. Euvolemia should be maintained using isotonic fluids. Finally, pain and agitation must be aggressively controlled, as they can cause significant spikes in ICP. This often requires continuous infusions of analgesics like fentanyl and sedatives like midazolam. If the patient is intubated, neuromuscular blockade may be necessary to prevent coughing or straining against the ventilator. If ICP remains elevated despite these Tier 0 measures, we escalate to Tier 1 interventions, which primarily involve hyperosmolar therapy and CSF drainage. Hyperosmolar agents work by creating an osmotic gradient, drawing excess water out of the brain tissue and into the intravascular space, thereby shrinking the brain. The two main agents are mannitol and hypertonic saline. Mannitol is an osmotic diuretic given as an intravenous bolus at a dose of 0.25 to 1 gram per kilogram. It has a rapid onset of action and also improves blood rheology, which can enhance cerebral blood flow. It must be used with caution as it can cause dehydration and electrolyte abnormalities. Serum osmolality must be monitored and kept below 320 milliosmoles per liter to avoid renal failure. Hypertonic saline is an increasingly popular alternative. It comes in various concentrations, most commonly 3%, and can be given as a bolus or a continuous infusion. It creates a similar osmotic gradient without causing the significant diuresis seen with mannitol. Serum sodium levels must be monitored closely, typically aiming for a target between 145 and 155 milliequivalents per liter. If the patient has an EVD in place, the drainage of CSF is the most direct and rapid way to lower ICP. Even removing a few milliliters can cause a significant drop in pressure, especially when the patient is on the steep part of the pressure volume curve. If the ICP remains refractory to Tier 1 therapies, we move to Tier 2. This tier includes more advanced and higher risk interventions. Therapeutic hyperventilation can be used as a temporary, bridging measure, particularly in a patient who is acutely herniating. Lowering the partial pressure of carbon dioxide in the blood, the PaCO2, causes cerebral vasoconstriction, which reduces cerebral blood volume and rapidly lowers ICP. The target PaCO2 is typically between 30 and 35 mm of mercury. However, it is crucial to understand that this is a double-edged sword. Excessive or prolonged hyperventilation can lead to critical cerebral ischemia. Therefore, it should be used judiciously and for the shortest possible time. Another Tier 2 strategy is the induction of a barbiturate coma, typically with pentobarbital. Barbiturates are potent suppressors of cerebral metabolism. By shutting down the brain's metabolic activity, they reduce cerebral blood flow and cerebral blood volume, thereby lowering ICP. This is an intensive therapy that requires continuous EEG monitoring to titrate the dose to achieve burst suppression, as well as significant hemodynamic support to manage the common side effect of hypotension. Mild therapeutic hypothermia, cooling the patient to a core body temperature of 34 to 35 degrees Celsius, has also been studied. The rationale is that it reduces the cerebral metabolic rate, but its efficacy remains controversial, with large clinical trials in adults showing mixed results. Finally, for patients with malignant, refractory intracranial hypertension that has failed all medical management, we must consider Tier 3, which is surgical intervention. The definitive life-saving procedure in this scenario is a decompressive craniectomy. This involves neurosurgically removing a large section of the skull, typically over the most swollen hemisphere, and opening the underlying dura mater. This allows the swollen brain to herniate outwards, through the bone defect, rather than inwards and downwards onto the brain stem. It is a drastic measure but can be life-saving in cases of severe traumatic brain injury, malignant middle cerebral artery stroke, or fulminant encephalitis. Now, let's shift our focus to a specific and fascinating cause of raised ICP, pseudotumor cerebri, now more accurately termed idiopathic intracranial hypertension, or IIH. This condition is defined by the presence of raised intracranial pressure in the absence of hydrocephalus, a mass lesion, structural abnormality, or CSF abnormality. The name pseudotumor was coined because its symptoms, particularly headache and papilledema, mimic those of a brain tumor. The older term, benign intracranial hypertension, is a dangerous misnomer, as the condition can lead to progressive and permanent vision loss if not treated effectively. The pathophysiology of IIH is not completely understood, but the leading theory points towards impaired CSF absorption at the level of the arachnoid granulations. There is also a strong association with cerebral venous sinus outflow obstruction, and MR venography often reveals stenosis of the transverse sinuses in these patients, though it is unclear if this is a cause or a consequence of the high pressure. IIH has a classic demographic. It is most common in obese females of childbearing age. However, it can occur in children, both prepubertal and postpubertal, and in males. There will be no this inserted audio clip if you buy the software license key or activation key. While often idiopathic, IIH can be associated with certain medications, including tetracycline antibiotics, high doses of vitamin A or its derivatives like isotretinoin, and both the use and withdrawal of corticosteroids. Certain endocrine conditions, like Addison's disease and Cushing's disease, have also been linked to IIH. The diagnosis is one of exclusion and relies on a strict set of criteria, known as the modified Dandy criteria. First, the patient must have signs and symptoms of raised ICP, such as headache and papilledema. Second, there should be no localizing neurological signs, with the important exception of a sixth nerve palsy. Third, neuroimaging, specifically an MRI with MRV, must be normal, showing no evidence of a mass, hydrocephalus, or venous sinus thrombosis. The ventricles are characteristically normal or small in size. Fourth, a lumbar puncture must be performed, which will reveal an elevated opening pressure typically defined as greater than 28 centimeters of water in a properly positioned, relaxed child, but the CSF composition, including protein and cell count, must be completely normal. Finally, there must be no other identifiable cause for the intracranial hypertension. The management of IIH has two primary goals: to alleviate the debilitating headaches and, most importantly, to preserve vision by relieving the pressure on the optic nerves. In patients who are overweight or obese, weight loss is the cornerstone of long-term management and can be curative. The first-line medical therapy is acetazolamide, a carbonic anhydrase inhibitor that reduces the rate of CSF production. Topiramate is another useful agent as it also has weak carbonic anhydrase inhibitory effects and can help with both headache prophylaxis and weight loss. For patients presenting with severe, acute symptoms, therapeutic lumbar punctures can be performed to remove CSF and temporarily lower the pressure. For patients with progressive vision loss that is refractory to medical therapy, surgical intervention is necessary. The two main procedures are optic nerve sheath fenestration, where small slits are made in the sheath surrounding the optic nerve to relieve local pressure, and CSF shunting, typically a lumboperitoneal or ventriculoperitoneal shunt, to provide continuous CSF diversion. In closing, let's summarize the most critical take-home points from our discussion on raised intracranial pressure. First, raised ICP is a time-sensitive neurological emergency governed by the physical constraints of the Monro-Kelly doctrine. The brain has limited compensatory capacity, after which even small volume changes can cause catastrophic pressure increases. Second, the clinical signs are age-dependent. In infants, look for a bulging fontanelle and accelerated head growth. In older children, the classic triad is headache, vomiting, and papilledema. Always be vigilant for signs of herniation, especially Cushing's triad, which is a pre-terminal sign. Third, management is a structured, tiered process. It begins with fundamental supportive care like head elevation and sedation, escalates to aggressive medical therapies like hyperosmolar agents, and reserves invasive measures like barbiturate coma and decompressive craniectomy for the most refractory cases. Fourth, the primary goals of management are to maintain an ICP below 20 mm of mercury and, just as importantly, to maintain an adequate cerebral perfusion pressure to prevent secondary ischemic brain injury. Finally, remember that idiopathic intracranial hypertension, or pseudotumor cerebri, is a distinct clinical entity diagnosed by excluding other causes. Its main threat is not to life, but to vision, and management is centered on lowering pressure to protect the optic nerves. Thank you for joining this critical deep dive into raised intracranial pressure. A firm grasp of these principles is essential for effectively managing critically ill children and preserving neurological function in the face of this formidable challenge.